Hello everyone, I'm Tanuj Dada from India. A very warm welcome to this webinar of the Asia Pacific Glaucoma Society. Today we are covering minimally invasive glaucoma surgery bypassing the trabecular meshwork, and this webinar is sponsored by Glaucos. Next slide. So I would invite all the viewers to join the Asia Pacific Glaucoma Society. It's a premier glaucoma society of the Asia Pacific region with a mission to have education research for all its members of the highest quality possible. Once you become a member, you have several benefits. You get a discount to our APGS conference. You get access to all our exceptional webinars, master classes, and joint symposia. You also get access to the Journal of Glaucoma, the Asia Pacific Glaucoma Guidelines. You can actively participate in our programs, and you're also eligible for awards and special recognition given out by the society. Next slide. So I encourage all of you to become a member of the society, and we have made it very simple. You can just scan this QR code and get access to the membership. Next. You can see once you become a member, in the previous 2 years, we have had several fascinating webinars joined with the American Glaucoma Society, the European Glaucoma Society, the World Glaucoma Association, and several educational events. And all this you can access in our resource library after you become a member. After this webinar, we'll be sharing a short survey with you. You can complete the survey, and then we'll be issuing you a certificate of attendance for this webinar. Important thing is that there may be several questions because there's a new techniques being presented. So please free to post your questions in the comment section, and we'll try to answer all the questions at the end of the 3 talks before the conclusion of the webinar. And once again, I would like to thank today's sponsor for the event, Glaucos, for sponsoring this webinar. Our first speaker is a world-renowned surgeon, Professor Leon, from a consultant from the ophthalmic surgeon from the Manchester Royal Eye Hospital. He is an internationally recognized figure, a clinician scientist par excellence, and has several innovations in glaucoma surgery to his credit. So the floor is all yours, Leon. Please share your presentation.
Can I just see? Can you see it? Because I can't see you, and I'm not even sure I'm muted.
Yes, Dr. Leon, we can see the slides. All good.
Okay, so I'm good to go, yeah?
Yes, all good.
Yeah, that's great. Thanks, Tanuj, and thank you for APGS for the invitation and Glaucos for the sponsor. So yes, this is a long title: Early Intervention with Trans-trabecular MIGS Devices to Improve Patient Quality of Life. That last bit of the sentence is a big one, and I'm not so sure that I can definitely address it. I like the fact that if we're talking early intervention, and we're talking devices here, I have some financial disclosure with most of the companies. I think probably fair to say my presentation probably a little bit more heavily biased towards the Hydrus device purely because of the fact that of my personal involvement in terms of the research and so forth, rather than anything else. So trans-TM surgery, we have lots, and you can see on the screen just a little bit of it in terms of the devices that we have to implant. Of course, there's a whole range of operation where we remove the TM, and we are talking specifically about devices on this occasion. So we're going to ignore everything else on the right in terms of removing the meshwork. I love this bang technique. I just love the name of it. I think congratulations whoever came up with that. So we bypass the TM because all we're trying to do is to restore some physiological outflow. And I think that's important to remember what this is for, is restoring physiology, get down to a physiological IOP. So we all kind of nowadays understand that the trabecular meshwork is the problem where the drainage becomes impaired, so then the pressure goes up. We think the Schlemm's canal may not be fully patent throughout the 360 degrees, and we think some of the downstream collector channels can be blocked. So at least if we bypass the TM, we address at least 1 out of 3 of this issue. And so because the aqueous outflow generally is sort of radial going out rather than flowing around circumferentially, I think that's a mistake thinking that aqueous is going to flow around circumferentially. So it all kicked off with Glaukos. I have to say that I started in 2009/10. This is when Glaukos first came out with the smallest implantable device in human being, which is the iStent. And then the iStent bypassed the trabecular meshwork, which is the first generation. And then we started with 1 iStent, and then we started with 2 iStents, and even trial with 3 iStents, thinking that how many access point is advantageous. And it's kind of concluded that 2 seems to be a magic number. 3 may not be quite worth your while. And then since then, Glaukos has come up with the Inject, which makes it more user-friendly for a whole raft of surgeons, where we fire a small stent through the trabecular meshwork. So it sits there, and it is probably still remain one of the most user-friendly devices to bypass the meshwork to allow single-point access. The Inject comes with 2, and the latest version, the W, is the same concept, just with a bigger flange, so then it's less likely to be over-implanted. So then it still allows you 2 access points. And then the Infinite may be coming out that may be loaded with more stents to allow you more access point. And to get right, you need to get the placement correct. And I think this is the bit that there's still work to be done in terms of knowing exactly where the collector channels are. Because aqueous doesn't flow around the Schlemm's canal, it doesn't flow downstream 3 clock hours. So it still exits in a relatively sort of radial manner. You still need to place your stent at the right place, roughly where collector channels are. But if you get it right, and hopefully this video will show you that I've got 2 iStents here. If you look at the collector channels next to it, while I flush some fluid, hopefully you're going to see 1 or 2 of them blanches as we push some fluid through. That I think this one on the left, you can see that it just go white, which means that at least we've got an anatomical access to the collector channels. The other device that we have is the Hydrus. Hydrus is just a bigger stent, which we also implant ab-internally through the meshwork into Schlemm's canal. The idea is that you may access more collector channels and dilate the canal. So once I've got the Hydrus in here, when I flush some Vision Blue, you will see the collector channels and the downstream vessels lighting up blue right here, right now. And you can see this extensive network of outflow. And at least for me, that means that we have access, the collector channels have anatomical connection. This is not physiological, but at least we've got anatomical connections. So what's the big deal for the patients? Well, the big deal, certainly from a scientific IOP point of view, has always been consistently shown in this FDA trial, right? This is the iStent first generation, the Inject, and the Hydrus. Forget about the SiPass, which is now gone out. But we consistently got this FDA trial that I was part of for the Hydrus stent, at least, phaco versus phaco mix. And then Chelvin later on will tell you about what phaco can do. But essentially adding a mixed device like iStent or the Hydrus has consistently shown a benefit that you are more likely to get down to normal pressure of medication. So you are, for the iStent, you are 13% more likely. So phaco does a bit, but you increase your chances of getting normal tensive or no meds by adding a mixed device. And we don't know the percentage of that on the Hydrus based on their trial. The pressure lowering, roughly speaking, take it from me, phaco lower you by 5. This is washed out IOP. Adding a device drop you by another 1 to 2 millimeters of mercury. So the iStent give you an extra 1.5. The Hydrus give you an extra 2.3 millimeters of mercury of reduction. What's in it for the patients is always about the medication reduction. That seems to be the biggest improvement for patient. So including, this is the common success, 25% reduction on no meds. Phaco give you around about a 50% chance of achieving that, and adding a device up it by nearly 20%. And this is what you're going to tell your patient if you're going to offer them as a device on top of the phaco. The benefit is the fact that you are more likely to be off medication. So I can talk a bit more about the Horizon trial for the Hydrus purely because I was involved in the trial, and it's the only trial that ran all the way to 5 years. So it's pretty robust data to show you that in terms of being medication free, adding a device to the phaco, you're consistently more likely to be medication free by about 20%. That's what I tell my patient. I can add a device in, then it will give you 20% more chances to be medication free. Rather than being 46% medication free, you're 66%. And that is the benefit. And if you look at people coming in for surgery with one medication, which is about half of the glaucoma population that we have in the community, right? They're coming in on one medication, coming in for a phaco. Then if you do a phaco, you're about 48% chance to be medication free at 5 years. You can quote those figures. But if you add a Hydrus device from our trial, then you're 73% more likely. So you add a device with minimal risk and you up your percentage by about 20-something%. And this is what you tell them, and you can take it or leave it depending on the funding situation, for example. IOP spike, after phaco, you can get an IOP spike, and sometimes they're unpredictable who gets it. Well, if you add a device, again, from the Hydrus Horizon trial, you are less likely to get a spike first day than somebody who's just having a phaco on his own, regardless of your pre-op IOP, interestingly. So just because pre-op IOP was 22 doesn't mean you're more likely to spike. So again, there's a little bit of that benefit for the patient that you can less worry about first day. So I don't see them first day in particular. This is the big one in terms of telling the patient that from a horizon that if you add a device like the Hydrus, you are 3 times less likely to require subsequent glaucoma operation at 5 years. So rather than doing a phaco, if I add a device, I tell you that you are 3 times less likely to need to have something like a trap or tube or diode or a Zen. And then that's a big deal. That is literally saving the patient having some serious operation. So gone are the days when we sit here, people ask me, how does the iStent compare to trabeculectomy? They are not compatible because we're not playing in the same field. So just the same example is the fact that angioplasty or a cabbage is a serious, successful operation for people who's got terrible angina and heart attack. But if taking an aspirin every day lower your risk of needing a cabbage, there is no argument that people would think take an aspirin. And here's the same. I'm telling you that if we add a device to your phaco, we reduce your chances to need to have a big operation. Why would you argue against that? And we extrapolate the data from the Hydrus, and when you look at the visual fields progression, again, be very careful. This is a post hoc analysis. Then it appears that the visual field progression in people who's had a mixed device like Hydrus appears to be less compared to people who's had cataract surgery alone. So you can have to draw your own conclusion on that, but visual field progression appears to be less if you add a mix. So all that comes to benefit for the patient. In terms of even for the EGS, mix tends to lower the pressure modestly and reduce medication burden. Well, it is true. And there are a lot of people on a lot of medication with eyes looking like this. And I think you guys all know this, that I think nowadays there's still just too many patients on too many GANs, eye drops, bimetoprost, brimonidine, those sort of stuff that is walking around with eyes like this, that is totally, utterly unnecessary. And I have to congratulate Glaukos for this one. So this, I came across, this is directly answering what I was asked to talk about, which is quality of life. And this is really one of the first paper that I really come across to talk about quality of life. So we'll talk about all these FDA trials that we've done comparing phaco versus phaco mix. And lots of these trials that we have done, there's always thrown in a quality of life survey and ocular surface survey. So there's always this questionnaire that we do at 1 year, 2 years, pre-op, and even at 4 years, 5 years for the Hydrus trial. The VFQ-25 is constantly featured. But interestingly, I always ask the company and I always ask the sponsors, like, we see some of this data and that's never really analyzed and published. But I congratulate iStent Inject from their pivotal trial that they actually did a post hoc analysis on these and published the result, which is very interesting and very enlightening. Again, take it if it's a post hoc analysis. It wasn't designed to analyze this. It wasn't powered for this particular person. This is not a primary or secondary outcome. So then you have to draw a little bit of your conclusion based on post hoc analysis. But nonetheless, if you look at quality of life, then it's fascinating to see that an improvement in the VFQ-25, significant improvement in the answers, is consistently more in people who's had an iStent inject with the phaco. Phaco inject group has consistently shown a bigger percentage of improvement in some of this quality of life questionnaire at every time point compared to phaco alone. And that's a big one. When we nowadays not just care about the IOP, we don't just care about medication, we don't care about just the visual fields, we care a lot, particularly when they come to funding from government money, about quality of life. This is the real powerful stuff we're seeing. Adding an inject improve some of the quality of life, certainly from a questionnaire point of view, over phaco alone. And the ocular surface disease index also show a significant improvement in a bigger percentage of patients who's had an inject with the phaco compared to phaco alone. And that's a big deal. That's a big deal that we all think is happening because you're on less medication, we assume, and the pressure is better controlled. And this is even more enlightening for me when you look at which aspects patients think is improved when they've had the surgery. Phaco iStent versus phaco alone. Then to my big surprise, one of the biggest improvement was driving. And that's huge, that people feel that they drive better. They see better to drive, are more confident. The bigger proportion of people see improvement when they've had a MIGS device like the iStent Inject. And that is affecting our patient day to day, considering the fact that glaucoma is an asymptomatic condition. It becomes symptomatic when you start treating them. And the first thing most of our patients lose is not the eyesight, it's the driving license. And this is a big deal for me. And this is fascinating to see. And last but not least, I'll be selfish to quote my own. In terms of when we looked at our long-term outcome for the first generation iStent that Glaukos launched years ago, this is phaco iStent. When we looked at the 7-year outcome, admittedly, interestingly, a lot of patients unfortunately died during 7 years because of the age group that we're dealing with. But you can see that consistently pressure lowering to about 16, 17. And that's what we tend to get with meshwork operation. And not only the visual field stays the same, cup disc ratio stays the same over 7 years period, but this is the important bit that we find that when before the surgery, we were seeing them around about 2 point something times per year. And after the surgery, we see that we're seeing them 1 point something times a year. We reduce the need for them to come back for follow-up. So this is it really. And I think that whatever benefit you see, and I want to end on this patient still walked into my clinic just 2-3 weeks ago from a fellow unit. She is on 4 different eye drops with an eyes looking like this, and she's afraid to go out. She doesn't like to go out, and she's had no operation whatsoever in her. And this is the visual field she's got. Pressure is 30 and 26. This is how tight the lower lid is. These are completely, utterly avoidable, preventable occasions nowadays. We have so many options, so many mixed options that we should be intervening very early, and no one should be walking around with 4 lots of eye drops, as far as I'm concerned, until they've had 2 tubes in their eye and you really run out of options. Thank you very much.
Request all the viewers to please post their questions in the comment section and be specific for the speaker whom you're addressing, and we'll try to answer them all after the end of the webinar. And I would now like to go on to the next talk. Our next speaker is Professor Zhu Li Yap from Singapore. She is the deputy head of the Singapore National Eye Center Eye Clinic and a clinical assistant professor at Sing Health, Duke, NUS. So over to you, Dr. Zhu. Please share your slides.
Okay. Are you able to see this? Is that working?
Yes, it's working. It's on full screen now.
Okay, great. Hi, thank you. My name is Zhu Li, and thank you so much to APGS and for inviting me, and Glaucoma as well for sponsoring. So my topic today is whether the iStent is within the realm of the general ophthalmologist. These are my financial disclosures. Well, I work in a very large tertiary center, so any suspicion of glaucoma and the patients are immediately sent to us. But in the community, the general or comprehensive ophthalmologist does manage a large number of mild to moderate glaucoma cases. Most of them are familiar with the medications and lasers that we regularly use as a glaucoma specialist, and referrals are really only made when they judge the patients to be progressing and requiring further intervention. So, this is where minimally invasive glaucoma surgery comes in. It's been designed and appears to consistently enhance the intraocular pressure reduction provided by cataract surgery, specifically in the mild to moderate glaucoma cases. And this is the group our general colleagues manage. They're relatively safe and straightforward procedures, which don't really require intensive follow-up, as Leon has pointed out, that filtration or tube surgery requires. Yes, there's an active ongoing debate regarding the effectiveness and longevity of the various MIGS, but overall there's consensus that they lower the intraocular pressure and reduce reliance on traditional glaucoma medications. And along with that, it helps to reduce other issues such as medication compliance, ocular surface disease. And it's cost effective. You can see in this US study that the phaco MIGS arms were cost effective compared to cataract surgery alone at 5 years, with more QALYs gained. Of course, we do have to remember that these calculations are system and country specific, time specific, and measurement specific as well. So while the administration of MIGS devices has traditionally fallen, under the purview of glaucoma specialists, recent advances in its design and ease of use and the evidence-based outcomes have expanded the applicability to the broader spectrum of ophthalmologists. So we know that phaco alone does lower intraocular pressure significantly, something again that my colleague Dr. Sng will talk about shortly. But for the general ophthalmologist, a MIGS can be employed so that it can work synergistically with cataract surgery. And then, of the current options currently available, really a TM bypass device would be the way to go, because TM procedures such as GAT or Cahook may require washout and maybe further care that a non-glaucoma specialist might not be comfortable with. And with the subtenos devices, they're technically a little bit more challenging and require a bit more follow-up as well. And there's also a higher probability of requiring intervention, such as needling. I was asked to speak about the iStent, so that's what I'll focus on, though obviously I do use other MIGS in my practice. The iStent Inject creates two patient bypass pathways through the TM, resulting in multi-directional flow through the Schlemm's canal. I think this is something everyone knows. We know it has proven efficacy in lowering the IOP over just cataract surgery alone. Even though one might argue that the IOP lowering is modest, the decrease in medication reliance really shouldn't be minimized. They have the longest term clinical data, being the first one in the market, with multiple long-term studies and follow-up of 4 years, 8 years even, showing significant IOP reduction and mean post-op IOPs, usually in the low to, well, not low, in about the mid-teens, with medication reduction ranging from 20 to 75%. And then there's independent data from over 20 countries across highly diverse populations, both in ethnicity and the type of glaucoma, which have demonstrated both the efficacy and safety. And it's safe. There's minimal effect on corneal endothelial cell loss, and it's refractively neutral. However, there's also the problem with malpositioning. So obviously it doesn't function as it's meant to when it's not placed in the proper place. There's a small study of 25 eyes done in Switzerland showing that overimplantation meant that it didn't work as well. But now there's the widely used third generation iStent Inject W, which includes a wider base flange, which got 360 microns versus 230 micron previously, I think, to increase the visibility during surgery and reduce the risk of overimplantation. And then, of course, you place it in the completely incorrect place, like the ciliary body or the cornea, which I've seen being done. I can't stress this more, that for the iStent, for any MIGS device, you should have good visualization. And if you don't have an on-fast view, don't implant it. Reposition the patient's head, reposition the scope, reposition the corneal lens, because if you're not going to place it in the right position, you may as well just not insert it at all. And so these are some pictures that are of well-positioned stents. they're provided by Glaukos. But even here, you can see on the leftmost picture, the iris is slightly vaulted upwards and just about touching the stents, which I've counted quite a few times in East Asian eyes. I think it's just particular to their anatomy. There was a recent small study in Germany looking at about 28 implantations in 14 eyes, where they analyzed the iStent positioning and graded it based on the anatomical landmarks of the chamber angle. So they wanted it to be in grade 2 or 3 area. And all of these patients underwent phaco iStent, and over 60% of the stents were implanted as intended within the TM region. But interestingly, 25% of those implants were below the TM, and there was still a significant IOP reduction found in all patients at 1 year, though how much of this was from cataract alone wasn't really discussed or touched on. So should the general ophthalmologist be implanting the iStent? Well, I mean, the case for it really is that it's been engineered with user friendliness in mind, doesn't have too steep a learning curve, and because of this and the simplified procedural steps, it makes it accessible to ophthalmologists from diverse backgrounds. And the patients being seen by the general ophthalmologist often have early stage glaucoma. It's exactly the group being targeted by iStent and many other MIGS. The integration of iStent in conjunction with cataract surgery, I mean, which is already routinely performed by the general ophthalmologist, allows for simultaneous management of the glaucoma and cataract, which optimizes your patient outcomes. And the general ophthalmologist has already been managing the patient for some time, and they probably have a strong doctor-patient relationship and could be well positioned to identify candidates who could benefit from the iStent. And also the patient would be more comfortable with them as their regular ophthalmologist. But there are potential benefits of incorporating the iStent for these general ophthalmologists, but there are also valid reasons to exercise caution and consider the limitations of its use. Glaucoma management involves intricate knowledge of the disease progression, the various treatments, and the treatment options. And, you want to have the ability to make a nuanced decision based on individual patient factors. So you don't really want to have, for any condition, you wouldn't want a doctor who is only offering one type of surgery because it's the easiest and the only one that they know how to perform when the patient might benefit from a different procedure. Yes, the iStent is designed to be user-friendly, but implantation still requires a level of technical skill and precision. And, some of the general ophthalmologists may not be so familiar with doing gonioscopy on a regular basis, but that can easily be changed. And, these patients do require regular follow-up as well and may need further intervention. And of course, in some regions, regulatory guidelines may restrict the use of certain medical devices to specialists with specific qualifications. So I think generally it is justified for a general ophthalmologist to use the iStent within a particular subset of patients, namely those with stable, mild to moderate glaucoma who are undergoing cataract surgery. As with all interventions, I think carefully consider the limitations and potential drawbacks. Patient safety and the outcomes should be prioritized over all else, and ensure proper training is undertaken. Really know the angle structures well and ensure gonioscopy is regularly performed. And good visualization, not like this, not with all this striae, is essential. So I'll leave you with the last few videos, which this, when it goes well and everything is, smooth, you can implant these fairly easily. As you can see, these are in the right position. And then when it goes not so well, it can get a little bit tricky. It's not so straightforward in some cases. So that went fine with the first iStent, but with the second one here, you'll see trying to get better visualization, but then it doesn't go in, and then you might spend, this is obviously a few seconds, but it took a long time to rethread this inside the eye. Luckily, good outcomes, ended up having to managing to put it in the right place thereafter, but it can get a little bit, knuckle biting at times. Okay. How do I stop sharing?
Thank you, Professor Yap, for your presentation. And I request again the audience to please post their questions specific to the speaker in the comments. We move on to the last section of this webinar, and that will be a presentation by Professor Chelvin Sng from National University of Singapore. She is also medical director of the Chelvin Sng Eye Center and is the convener of the MIGS interest group of the Asia Pacific Glaucoma Society. So the floor is all yours, Chelvin.
Good afternoon. My name is Chelvin Sng from Singapore, and I'd like to thank the APGS for this kind invitation to speak on the topic, Is Lens Extraction the Best Mix? These are my financial disclosures. Cataract and glaucoma are the two most common causes of visual impairment worldwide. It has been reported that between 6 to 19% of patients undergoing cataract surgery also have glaucoma. Certain types of cataract are well known to cause glaucoma. On the other hand, the treatment of glaucoma, such as surgery and laser procedures, can cause cataract. Cataract surgery in glaucoma patients can also be challenging, including small pupils and floppy irises. In this eye with angle closure, you can see how the pupil progressively gets smaller during capsulorhexis. Eventually, I had to put in iris hooks to proceed. Cataract surgery has benefits for the glaucoma patient beyond just improving vision. Removing the cataract helps with the diagnosis and monitoring of glaucoma. Perimetry is more reliable as lens-induced artifacts are eliminated. So while lens extraction can be beneficial for glaucoma patients, is it the best minimally invasive glaucoma surgery? To examine this, let us look at the original definition of MIGS. And indeed, we will all agree that lens extraction fulfills the criteria of a high safety profile, ease of use, ab-internal approach, minimal trauma, and rapid recovery. Where the issue gets a little bit more contentious is whether lens extraction has at least moderate efficacy in lowering the intraocular pressure. Let us look at the efficacy of lens extraction in these subsets of glaucoma: lens-induced glaucoma, angle closure glaucoma, and open-angle glaucoma. For lens-induced glaucoma, the pathological lens plays a major role in increasing the IOP. Hence, for lens-induced glaucoma, lens extraction is essentially glaucoma surgery and can reduce the IOP drastically. However, even in these cases, lens extraction may not be enough. In this largest case series of phacolytic glaucoma reported, the authors recommended trabeculectomy when symptoms exceed 7 days or preoperative IOP control was inadequate or maximal medical treatment. Adding trabeculectomy to lens extraction in these patients prevents postoperative rise in IOP and decreases the need for systemic hypertensive medications. Is lens extraction the best mix for angle closure glaucoma? Lens extraction is well known as a treatment modality for angle closure glaucoma, especially in the context of a bulky lens. Removing the lens widens the angle and lowers the IOP. The EAGLE study is a landmark RCT that compares early lens extraction to iridotomy in eyes with primary angle closure and found that lens extraction was more effective in lowering the IOP and reducing the glaucoma medications compared with laser iridotomy. Lens extraction alone reduced IOP by 40%. However, after cataract surgery, about 1/3 of patients still require glaucoma medications. This retrospective cohort study compared phaco-only versus phaco with 2 iStents in angle closure eyes, and these 2 iStents can be either G1s or G2s. They showed that the IOP was lower in the phaco iStent group with less medications at 1 year. The incidence of IOP spikes was significantly greater in the phaco-only group compared with the phaco-stent group. Interestingly, they found that even in angle closure patients, almost 20% of angle closure eyes required more glaucoma medications after phaco alone, compared with only 4% of eyes after phaco iStents. In Singapore, I collaborated with Jason Cheng's group at Kotek Puat Hospital to publish this prospective randomized controlled study comparing phaco alone with combined phaco and one G1 device in patients with angle closure disease. We showed that the IOP was similar in both groups, but the complete success rate was significantly higher in the combined phaco and iStent group because more patients were medication-free. This is likely because the chronic iridotrabecular contact damages the trabecular meshwork and outflow pathway, such that even after the angle opens up after lens extraction, aqueous drainage is still impaired. And phaco is not completely without risks. Early post-operative IOP spikes can cause wipeout and irreversible visual loss. Lastly, is lens extraction the best mix for open-angle glaucoma? This meta-analysis showed that for angle closure glaucoma, phaco lowers IOP by 6 millimeters of mercury, while in open-angle glaucoma, IOP was reduced by 2.7 millimeters of mercury. The evidence was noted to be weak but consistent. The mixed pivotal studies consistently show that lens extraction alone reduced the IOP by about 5 millimeters of mercury. But combined lens extraction with mixed devices is definitely more effective in lowering the IOP. While the mechanism for lens extraction lowering IOP is obvious for angle closure glaucoma, the mechanism for doing so in open-angle glaucoma eyes is a subject of debate. Several theories have been proposed, but these are often speculative and controversial with not much supportive evidence. This study showed that even in primary open-angle glaucoma eyes, the greater the lens fault, the lower the IOP after the surgery, suggesting that even in open-angle eyes, IOP is lowered by widening the angle further. This has led some ophthalmologists to proclaim that a glaucomatous cataract is no longer limited to the categories of phacolytic, phacoanaphylactic, or phacomorphic glaucomatous disease, but should be a consideration in any glaucoma patient who could benefit from sustained decrease in IOP from cataract removal and has some degree of visual disability from cataract. Personally, I don't agree with this statement completely because the data quality of studies showing IOP lowering in open-angle glaucoma is poor, and many studies did not include colonoscopy, and they may well have included angle closure eyes. The predictability of IOP decrease after cataract surgery is also poor. In this study, a significant proportion of eyes, about 1/3, had an increase in IOP after cataract surgery, requiring additional medications or laser. Hence, in my opinion, cataract surgery alone is not an appropriate glaucoma surgery for medically uncontrolled open-angle glaucoma. IOP spikes can also be blinding for eyes with advanced glaucoma. On the other hand, there is very good evidence that combining cataract and glaucoma surgery results in lower long-term IOP than cataract surgery alone. We have discussed the efficacy of lens extraction as a mix in various subsets of glaucoma. In summary, lens extraction can reduce the intraocular pressure in patients with glaucoma, but the predictability and consistency is poor, especially for open-angle glaucoma. We mustn't forget that lens extraction can also result in IOP spikes, as well as long-term IOP elevation and an increase in the number of glaucoma medications. Patients with medically uncontrolled IOP, multiple drug allergies, and poor compliance to medications should consider combined lens extraction and glaucoma surgery instead of lens extraction alone. Thank you very much for your attention.
Thank you, Chelvin. So we come to the end of the 3 talks, and now we are opening up the Q&A session. So I would like all speakers to come live, and please unmute. So the first set of questions is for Dr. Leon. So in the Asia Pacific region, we have a number of countries where the per capita income is not that high, and making the expensive iStent or the hydrus is may not be such a feasible option. So, Leon, do you think as a cost-effective MIGS, would you recommend any of the incisional procedures like bang, KDB, or a limited GAT as viable alternative to any of these very expensive procedures?
I think would be it's a difficult one to answer, Tanuj, and I mean realistically, yeah, I can't tell you whether it's cost effective, and cost effectiveness measurement is so difficult in terms of depends on your region, depending on how you're measuring, depending on. So I think that's so many factors. And scientifically, I'm not entirely sure you can extrapolate. You know, in terms of devices trial, we have some of the most robust devices trial. In terms of the FDA trial, it's some of the best, most well-designed, strict trial. And a lot of the non-devices trial, the bang and the canaloplasty and the KDB and so forth, doesn't quite have the same robust trial. Yeah, I mean, I think you have to agree with that a lot of them are just longitudinal case series, single center, single surgeon. They don't have this multi-center FDA trial, and FDA trial is really tight. So they show similar results. So can you extrapolate? I'm not so sure you can. So certainly the quality of life data that I've shown you, the visual field data we've shown you, the reduction of need for subsequent surgery that we've shown you with particular device, I'm not so sure you can extrapolate with the bang or with the GAT or with the other meshwork removal. But yeah, if you don't have the cost for those devices, the meshwork removal probably will get you similar things, but it's a different risk profile. And I'm personally not a fan of removing meshwork.
Leon, the next issue is that you mentioned that when you combine the phaco with MIGS, phaco lowers IOP by 5 millimeters of mercury approximately, and then 1 to 2 millimeters you get additional lowering with MIGS device.
Yeah.
So if you see the efficacy of phaco, it's very high in the first year. When after first year, if you follow a patient with phaco alone, the IOP lowering does not sustain. So I just want to ask you, in the long term, if you take away the effect of phaco, then the IOP lowering just attributed to MIGS will be very minimal. So would that be a concern for a patient requiring a target pressure in the mid-teens or the lower teens?
I suppose that I'm going to address that. The two things that you mentioned, the fact that the phaco effect wears out at 1 year. And we've always said that. When you look at this FDA trial, it does not say that. And this is what we consistently get surprised. If you look at the FDA trial that we've done, you look at the Hydrus trial, you look at the Inject trial, the phaco alone group in the mild to moderate glaucoma, I mean, be careful about the inclusion criteria of these. They've all got high pressure above 22, less than 35, washed out. And the phaco group consistently stays down. In the Hydrus group, they stay down for 5 years. It's the same argument that the SLT only lasts a year or two. Well, actually, in the light trial, they last all the way up to 6 years. So I'm going to challenge you to say that the phaco effect may not wear out as early as you think in the very mild to moderate group. And I'll give you that. And then, but yes, adding a device drop you by an extra 2 millimeters of mercury on average. Out of 500 odd patients, a 2 millimeters drop is a big drop.
So Leon, I'm sorry,
Yeah.
I'm just gonna come in here and say something really controversial. So I do have my doubts about the FDA studies because they claim that the phaco alone can reduce IOP by 5 millimeters of mercury.
Washed out.
Yeah, washed out IOP. But personally, I've not encountered that. I don't know about you in open angle glaucoma eyes. I've not seen so much reduction in IOP after a phaco alone. And
I know, but
I think
you never wash them out, those Chelvin. You never wash them out, do you? They don't come in washed out with a pressure of 27 and you do a phaco and you get down to 22. I mean,
yeah, but even on the same drop. So sometimes after phaco, I keep them on the same drops, and they don't go down by 5.
they
You know,
don't. But they don't. But that's not washed out.
yes, there's some
it's
of
a
them.
massive difference when they're on latanoprost. That drops you down by a lot. And then whatever additional effect, I think is very minimal. It's like adding timolol to latanoprost, drop you down by an extra 1 or 2. But timolol alone drops you quite a bit.
Yeah,
and
but I
just don't think
also
you'll get it.
I also have a little bit of doubt about the accuracy of some of these data in terms of the preoperative data. I think that there wasn't 2 observers taking the preoperative IOP at baseline. And perhaps there was some pressure to recruit from these studies. I mean, they were commercial studies, the patients were reimbursed. So I do think that I do have some doubt about the accuracy of the washed out IOP reduction. I think there is, we certainly can't exclude that until we do a proper trial with preoperative IOPs taken by 2 observers. I think that will be much more proper.
When you say 2, right? I mean, they are done twice. They are washed out. So that means they are taken in morning, midday, and evening. So there's a diurnal IOP washed out. I check the pressure. Someone else reads the pressure.
Yes. So
which is better than anything that we do in clinic on a Friday afternoon.
Absolutely, but I do think there could be a little bit of bias. We can't exclude.
Oh, without a doubt. Everything can be biased.
Yeah. So I don't see that in real life data. So I'm just saying that it seems that phaco has an unusually high effect on POAG IOP post-op alone. So looking at the previous meta-analysis, it was only about 2.7 millimeters of mercury for phaco alone in POAG eyes.
They're on medication though.
Yes,
it's the same as SLT. It's really the same as SLT.
I think the jury is out there, and we only know this after we do a proper study with 2 observers taking the IOP before surgery.
Have any of you have experience with the phakic MIGS, with the phakic iStent without removing the cataract?
Yeah.
Yeah.
So what is the IOP lowering there?
Variable.
It's not that much. So I mean, if we go and read the compare trial, then when we compare the 2 iStent with Hydras, then again they were washed out. So then there was medication, there was IOP reduction, but read that very carefully because we did not have a washed out IOP again at 1 year and 2 year. So we couldn't really compare. So pre-washed out, they're running something like 26, 27. And then at 1 year, I can't remember what, they were in the teens, but they weren't washed out. So then, I don't know for that matter. And I think that, yes, I don't think you get that much for sure. But then it kind of, it's not something that I would tend to go for in a phakic patient or pseudo-phakic for that matter.
So Dr. Yap, one question for you. You think the iStent Infinite is going to be a better option as compared to the Inject? Any views on that? Professor Yap?
Oh, sorry, I didn't. Well, I think the studies are promising, and I think there was a study coming out of Tanuj Sng in Singapore where they were putting in 4 iStents, and that seemed to work quite well. But it's not very cost effective for the patient, iStent Infinite also has an infinite number of shots. So right now, the iStent Inject and iStent W, you have 4 tries before you don't have any more, right? So like, the video I showed where you have to rethread. And so if you've used up 4 shots, that's it. You're going to have to just take the stent out or open another one. But with the Infinite, presumably if you get it wrong, you can take it out, replace it, rethread it, and really get it in the right place. So hopefully by implanting the stent in the, having all those tries where you get to inject it in the correct place, it should work better.
So there's a question, Chelvin, is there any role of MIGS, the iStents in normal pressure glaucoma?
Well, I think there's a limited data that shows that it may bring down the pressures. But personally, I wouldn't go for the mixed procedures in patients who require very low target IOPs, like in the low teens or below 10. I think we can't expect the trabecular bypass devices to achieve that. But certainly if a patient has NTG and in the high teens or even 20, very borderline high pressures, you can attempt to do a phacoplast procedure with a trabecular bypass device if the IOP is already controlled on medication.
Okay. So, Leon, there's a question by Dr. Medani. Do you think early phaco plus MIGS is better for glaucoma even in a clear lens?
Oh, I think clear lens extraction is a different game, and I don't want to tell people to take lens out willy-nilly unless they fit the criteria for ego, which then we were talking about narrow angle here. So I think that's a different game. And if they don't fit the ego criteria for narrow angle, I still wouldn't recommend clear lens. So no, but on the other hand, I think nowadays I do have a lower tendency to take the cataract out with the MIGS. So
Yeah.
in the journey of this patient, if they've got a little bit of symptoms and the vision is 6.9, let's say in the UK world, which is still good, but they used to be 6.6 and they're 6.9, I've got a bit of early cataract, then yes, I have a low tendency to do the cataract combined with the MIGS. Based on our data and experience, then it just buy me some more time, so they won't need some medication and they are less likely to need subsequent surgery. So I will have a tendency to do so. And the second place is that I have a tendency to do that if they are on multiple drops, like a lady that I show you. Then if I can do a phaco plus a MIGS, get them off drops a little bit, buy me 6 months, 9 months, then trap them later. Because I hate phaco trap to the nth degree. I know you
So
love it.
Leon, okay, Leon, you mentioned like there's a lot of studies on misplacement of the iStent. So, do you recommend that after you put in the iStent, you always do the dye test to ensure that the channels are patent, and in case you inject the dye and you don't get outflow, then would you change the location or what would you do then?
Uh, I, I'm going to divert it to Zhu Li in a second because about the misplacement of it. I'm not entirely sure that the dye test, I used to do it and I used to find it useful. I even do a sub-analysis and I thought if the dye test positive, they did better. But then when we got enough patients on board, then the significance become less. So I used to do it out of interest, and I suppose I still sometimes do it, but maybe not with vision blue. If I see blanching, if I think I've got connections, I am more inclined to stop medication. That's about it.
I think the dye test sort of tells you whether your implant is in the right place. It may not mean that it might work. I mean, depends on the episcleral venous pressure as well, but at least shows you that it's in the right place. So I do that sometimes to confirm the position of the implant. And if it's not in, sometimes I would readjust it, actually take it out and put it in the right place.
Okay. So across all studies that you showed, it comes out that the IOP lowering efficacy of the Hydrus is better than the iStent, even with 2 iStents. So what would be your indications for preferring iStent over Hydrus or a Hydrus over iStent for any specific patient? Or you feel that higher the circumference of the device, better is the IOP lowering efficacy? So first Leon, Chelvin, and then Dr. Yap.
I don't think I showed
Leon.
I don't actually think I showed that. But I think if you put it head to head on a very strict criteria like the compare trial, there is a difference, particularly medication count. Whether in real life the difference really is significant, I'm not 100% sure. You know, that I think that in real life the difference between a latanoprost and bimetoprost is nothing. Although there may be a millimeter mercury of difference. So I think it's a similar example. And ultimately, I always say that a poorly placed Hydrus is not going to do better than a well-placed iStent. So if you can't get it in, it doesn't work. So I think iStent is easier to use, and not every angle can take a big device. So we don't need to favor one or the other. I just don't get why glaucoma people love only one person or one device. You know, there are so many different size and shape of people's and eyes. Then there is enough. I think it's nice to have both.
Chelvin,
Well,
what do you
I do agree with Leon. I think it's very surgeon dependent, depends on what the surgeon is comfortable with and is able to get most into the angle. So personally, I find the Hydrus easier to get in the right place in the Schlemm's canal compared to the iStents, simply because I think different trabecular meshworks have different stiffness. So the amount of force needed to indent the trabecular meshwork to get it into the Schlemm's canal varies for every single person. And I've shown that in my own patients with the dye test. However, I would say that if a surgeon is more comfortable with the iStent and can get it in more reliably than the Hydrus, then go for it. I think it's very surgeon dependent.
Okay.
Yeah, I mean, I agree with both their points as well. You know, and I think, you know, with you, like, it's just nice to have all of these devices at, you know, at our disposal for us to use, and then you just adapt. I mean, I know there are patients who are being, like, for example, this is off-label use, but I know that there are people who are using the iStent more so in angle closure eyes as well. Again, this is off-label because the hydrus is too large. We put in these angle closure eyes. I personally like using the iStent in very high myopes because I've had some experience with the hydrus not being placed very well, or I've had issues with it in very, very high myopes. So I prefer that, So I just, with everybody, with all these stents and devices, I think it's just surgeon dependent, but also important to see whether the patient requires it. I mean, what they require. Yeah.
Okay. So there's one more thought that if you do viscodilatation of the canal and then put in these devices, would that be a more efficacious option, Leon?
You asked me early on whether a device is too expensive. Now you're talking about two combined mixed procedure.
No, just injecting viscoelastic with a cannula, not any other MIGS device.
I know, but to dilate the canal with a cannula will require either an eye track or an anomaly. So the cost is prohibitive. But yes, I like the idea of a 360 cannuloplasty followed by a device. So, I think the dilation alone may not hold. If I dilate and place a device like a stent, then it makes sense. But the cost is prohibitive in many, many settings, including mine.
Okay. And the last question, I think once your iStent or hydrus, whatever you have implanted, has failed and the patient IOP is up again, what is the next surgical option that you choose for your patients?
Ladies
Leon?
first.
Well, I mean, it
Come
really
on.
depends on how advanced the glaucoma is, or
No, we're talking only for early to moderate glaucoma, and you have put in these devices, and after a few years, pressure is again up. So, what is the next line of management?
Oh, I mean, I would usually just restart drops for the patient, assuming that they're not on drops at that point. I think some people have also done SLT if it hasn't already been done previously, because a lot of our patients in our community haven't had SLT performed. So that could be something that is done for them. Yeah. Chelvin?
Yeah, I think I'll agree with Zhu Li. I'll restart drops. I'm not sure how well an SLT will work if the trabecular bypass device hasn't worked. But yeah, certainly drops will be a good idea.
Leon?
Yeah, it's the same. I treat them like anybody else, like they haven't had anything, So starting back on drops, it has some SLT if they haven't had it, and then progress. If they're asking me whether I would stick another mixed device at the angle or do another angle-based surgery, generally I would probably say no. And I think if I've been there and done something and it didn't work, I tend to go somewhere else. Then I probably will go subconj. I may go suprachoroidal. I may do a trap if I think it's necessary. So I wouldn't place a hydrus after the iStent, and I wouldn't do a cannuloplasty after a hydrus. That's just me.
I agree. Yeah, I wouldn't either.
So I think there's one question just put up by the audience. Do you stop glaucoma drops post-op after the hydrus implant in patients on 1 or 2 drops? And when do you see the patient post-op after MIGS, especially hydrus, Dr. Nilima?
Yeah, I would stop the patient from their glaucoma drops, and I'd see them day 1 after surgery, week 1, and then month 1 after. That's what I would normally do for these patients.
Okay.
I'm not sure about the rest.
Yeah,
So
that's
I
the
think-
same regime that I do as well. So I stop them on drops because they're early to moderate anyway. So even if the pressure goes up a little, I'll pick it up and I'll start them back on drops and no harm done. So usually drops will be stopped after surgery.
So I think we have come to the end of our allocated time. And a big thank you to Leon, Dr. Zap, and Dr. Chelvin for this fabulous webinar. And I thank the audience for tuning in, and also Glaucos for sponsoring this webinar. And just to tell you about our upcoming events, stay tuned for our Young Glaucoma Experts program on 6th of September and another webinar on the 30th of September. These are done by the Asia Pacific Glaucoma Society. Next slide. And we have started a dedicated YouTube channel. So please prescribe to the Asia Pacific Glaucoma Society YouTube channel, where you can see a lot of educational videos, and that will help you in a better surgical experience. Next slide. And once again, a big thank you to today's sponsors, Glaucos, for this MIGS webinar. Next slide. And thank you once again. Stay tuned in for our emails. We'll keep you updated with our regular webinars and master classes. And once again, a big thank you to all our expert panel. It was really a very nice, educative session, and we learned a lot of new things and a good discussion after the webinar. And a thank you for the audience participation and your questions. So with this, we conclude today's webinar. Have a great day ahead. Thank you so much for tuning in. Thank you.
Thank you.
Thank you.